Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the Top 200 Study Guide. It's a 31-page PDF, absolutely no cost to you. Simply an email will get you access to that. So again, go take advantage of that, reallifepharmacology.com. We'll get you updates when we got new podcasts and other content available as well. All right, so the drug of the day today is Levomilnacipran, and this medication is also known as Fetzima, as its brand name. This medication is a serotonin-norepinephrine reuptake inhibitor. Often you'll hear this class of medication referred to as an SNRI. Nobody typically says all those words if they can help it. So, again, Fetzima being an SNRI, as you could expect, it's probably going to be used for psychiatric conditions, and it is FDA approved for the treatment of major depressive disorder in adults. So, how does it kind of differ? What's the difference between, duloxetine or other medications within this class? In my experience, duloxetine by far is the most commonly used SNRI. Probably second is venlafaxine or brand name Effexor. And that's probably just due to experience. They've been out the longest, that type of thing. So Fetzima specifically, or Levomilnacipran, it is not approved for anxiety or chronic pain conditions. And so the likelihood that you see it used for that, that's going to be an off-label use if you see a clinician do that. And again, people are for, chronic pain, neuropathic pain, fibromyalgia type situation. We don't have the evidence there, or at least as much evidence as we do with something like duloxetine. All right, let's talk a little bit about the selectivity in comparison to maybe other SNRIs. It tends to be more on the norepinephrine side than the serotonin side. And so when I get into adverse effects here coming up, when we think about norepinephrine, that's more on the fight or flight, amp you up type of side as far as adverse effects go. So again, I'll touch base with that when we're talking about adverse effects. A little bit on dosing. Starting dose typically around 20 milligrams once daily. It's oral. And then can be increased up to a maximum of 120 milligrams. All right, so let's get into side effects a little bit. As with most medications, one of the more common ones can be some stomach upset, that type of thing. On the thinking about the norepinephrine piece of it, which I alluded to. So if we think about some of the things that, amp a person up with norepinephrine, we can potentially run into some tachycardia, some increased heart rate, or blood pressure. Again, a lot of these adverse effects are dose dependent. So again, the higher the dose, probably the more likely you are to run into some of those cardiovascular concerns like tachycardia and hypertension. On the kind of central nervous system side of things, if we're thinking about, norepinephrine, probably more likely to cause some insomnia and anxiety than, sedation, for example. Another thing to think about, urinary retention, urinary hesitancy, so probably more so an issue in patients with a history of BPH rather than, maybe a younger, healthy 30-year-old. But yeah, urinary retention is something you can certainly pay attention to. And again, that's that alpha agonist type action that norepinephrine can have a little bit there. So again, that strong norepinephrine reuptake inhibition there might be more likely to cause that adverse effect. A couple other things, dry mouth, constipation, those have been reported there as well. Sexual dysfunction, I'll mention specifically. This may be a little bit less. So the more norepinephrine reuptake inhibitor we get compared to the more serotonergic side of things. So more serotonergic, like SSRIs, you tend to get more sexual dysfunction. So Fetzima might be on the side of maybe a little bit less frequently than SSRIs. Again, not totally not gone, totally not an issue, but there is some potential there due to that mechanism, and maybe a little less effects on the serotonergic side, that it might be a little bit lower rate than with some of the more traditional SSRIs. SIADH certainly has been reported with this medication, so monitoring for low sodium, and in particular patients at risk for that, who may be on other medications that deplete sodium as well. Loop diuretics are a good one that comes to mind that may impact those electrolytes significantly. There is boxed warning. There is a boxed warning with this medication that goes with pretty much all antidepressants. So again, paying attention to particularly younger adults in short-term studies, the risk of suicidal thoughts and behavior has shown to be increased. Over the longer term, that's typically not quite as much of an issue, or historically hasn't been in the studies and evidence. But in that short term, that's what that boxed warning is for. So again, something to pay attention to there. And similar to SSRIs, I do want to, and other SNRIs, I do want to mention discontinuation syndrome. This is a mistake I've seen in practice when, clinicians are trying to reduce polypharmacy, they're trying to reduce medications, and stopping a medication cold turkey, or the patient is on vacation and they go without it for a week or two or something, or multiple days. Patients can start to experience discontinuation syndrome. The higher the dose they've been on, the longer they've been on it, this is probably more at risk in those type of patients. But patients can get, some like flu-like symptoms sometimes, some nausea, vomiting, diarrhea. They can get headaches, feel dizzy, reduced appetite, sweating, chills. Those type of things can happen with that discontinuation syndrome of antidepressants and medications that affect the serotonin type pathway. So, bottom line, unless there's an urgent need to discontinuation, like there's a very, very serious side effect going on, it's typically always a good idea to taper off if possible. From a pharmacokinetic standpoint, there is some metabolism by CYP3A4. So if you've got CYP3A4 inhibitors on board, or you're looking to start a CYP3A4 inhibitor, keep in mind that concentrations could go up with a medication like that. There is dose adjustments, so a significant chunk of the drug is excreted in the urine unchanged. So in patients with an EGFR of less than 30 mils per minute, we may need to do some dose adjustments there and maybe a little bit closer monitoring. As far as other monitoring parameters, probably the biggest thing that I kind of pay attention to with SNRIs in general, and particularly as doses escalate of SNRIs, is those cardiovascular things, so blood pressure and pulse. That's something that I'm going to watch a little bit more closely, and obviously if patients are on other medications that worsen blood pressure and worsen pulse as well, that's something that I'm going to take a peek at a little bit more closely there too. So definitely important to think about that. And then, of course, I alluded to some of the kinetics. Renal function, changing renal function can potentially alter the concentrations of this medication. So, having that baseline renal function check periodically every year, every other year, that type of thing, can be certainly helpful to make sure we've got the appropriate dose there. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study materials like BCPS, ambulatory care, geriatrics, BCMTMS, NAPLEX, go check out meded101.com/store. We've helped thousands of pharmacists and pharmacy students pass their exam, and we can absolutely help you too. Each different study package is tailored specifically to the content outline. I personally look at those content outlines each year, making sure that our study materials are the best and trying to help you prepare for the exam. That's my goal with the study materials, is to prepare you for the exam. So again, go check out all those links, all those resources, metod101.com/store. All right, wrapping up with drug interactions. So first and foremost, when you have a medication with serotonin activity, it's certainly on my radar to watch for serotonin syndrome. And this is obviously especially true, when we're taking other serotonergic type agents. So, migraine medications like the triptans have serotonergic activity. Older generation antidepressants like tricyclic antidepressants, they can certainly have some serotonergic activity. Other kind of unique medications, tramadol for pain has some SNRI or serotonergic additive type effects there as well. Buspirone, St. John's wort, kind of a nuisance of a supplement, if you will, that can have some serotonergic activity as well as has a significant bunch of drug interactions there as well. So definitely think about that. Again, serotonin syndrome is very rare in general. I don't see it very often in practice. It does happen. But again, not very common. And, typically it's when a patient is on multiple medications or high dosages, or maybe in the situation of overdose as well, is when you're probably more likely to see serotonin syndrome, or at least that risk for that goes up there. I alluded to metabolism, so definitely use this medication with caution in patients taking CYP3A4 inhibitors. Specifically, strong inhibitors like some of the azole antifungals like ketoconazole. They can certainly increase concentrations of Fetzima. So pay attention to that, and then obviously, pay attention to the adverse effect profile. Increase in blood pressure. Worsening. GI upset. Whatever the case may be there, as far as the adverse effects go. Also wanted to mention kind of a drug-food interactions, those type of things. Grapefruit juice. So concentrations of this medication can go up with the use of grapefruit juice. It is a notorious CYP3A4 inhibitor. So pay attention to that. If patients have, fluctuating or started a brand new diet and now they're taking grapefruit juice every day, that can cause fluctuations in the concentrations of medications and certainly lead to a higher incidence of adverse effects, which we could see potentially happening with this medication if that's done. Alcohol, I did want to mention specifically as well. So actually with co-administration of alcohol and levomilnacipran, this can actually cause a more rapid release of the drug from the extended release tablet. So that could obviously, accelerate that absorption. Patients could get to higher concentrations and, potentially run into a greater incidence of adverse effects. So generally recommended to avoid alcohol with the use of that. And, makes sense in general. Alcohol is a depressant, so not a great thing to utilize with antidepressants there in general. Then I did want to mention MAOIs. Again, MAOI inhibitors are used very seldom in practice, and it's because they have a ton of drug interactions. And that drug interaction with Fetzima is contraindicated. So making sure there's a proper washout period where we stop taking the MAOI inhibitor if we're going to use a medication like Fetzima. All right, and last but not least on the drug interaction scope here, I wanted to mention sympathomimetics. So, stimulant type medications that can have additive effects to elevated blood pressure and potentially tachycardia. Again, which could certainly have some additive effects on top of Fetzima, which can do that as well. Again, Typically, I'm not crazy concerned about the lower dosages of Fetzima, but as you start to escalate, it's more and more likely that you're going to encounter maybe some modest bumps in blood pressure as well as pulse there as well. So again, something to pay attention to. In practice, if you've got a patient that you're having trouble with uncontrolled hypertension or their heart rate's going up, that's a situation where you definitely want to look at that med list, and Fetzima may play a role in that issue, and certainly should be looked at as a potential contributor at an absolute minimum there. All right, well, I think that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor, leave a rating review on iTunes, Spotify, whatever platform you're listening on. I greatly appreciate that. Of course, share the podcast with anybody that would benefit, who's preparing for board exams, pharmacology classes, so on and so forth. And don't hesitate to reach out to me as well. Eric Christensen, PharmD, BCPS, BCGP. You can find me on LinkedIn, or you can shoot me an email, mededucation101@gmail.com. With that said, please take the time, support the sponsor, meded101.com/store. I've got tons of resources for everybody, whether you're a pharmacy technician, nurse, pharmacist, med student. Go check out all those resources. Lots of clinical pharmacy things that any healthcare professional can definitely benefit from. So greatly appreciate that support at meded101.com. With that, I'm going to sign off for today. Thank you so much for listening. Take care, and I hope you have a great rest of your day.